My name is Reetu Mukherji, and I'm an assistant professor and gastrointestinal medical oncologist at MedStar Georgetown University Hospital, Lombardi Comprehensive Cancer Center in Washington, D.C. With over 1 million new cases in 2022 and an estimated 769,000 deaths, gastric cancer represents one of the most common causes of cancer death worldwide. It's the fifth leading cause of cancer and fourth leading cause of cancer deaths globally. And it has a higher incidence in men than women in a 2-to-1 ratio. And while upper GI cancers tend to be squamous or adenocarcinoma subtypes, lower esophageal GE junction and gastric cancers are more often adenocarcinoma. And while the incidence of gastric cancer is decreasing annually in the United States, this is really reflective of non-cardiac gastric cancer, and lower esophageal GE junction adenocarcinoma incidence is actually rising in Western countries, likely attributed to the increasing rate of obesity and GERD as well. And while advanced gastric cancer is often incurable, early-stage gastric cancers can technically be cured with surgery. But many patients with early-stage gastric cancers are asymptomatic when diagnosed, and up to 50% of patients have unresectable disease. Silent evolution, late clinical presentation, genomic heterogeneity, and resistance mechanisms to treatment all contribute to the high mortality rates of gastric cancer. Current United States guidelines for the treatment of advanced HER2 non-amplified esophageal GE junction and gastric cancer include chemotherapy or chemotherapy combined with immunotherapy. For HER2 non-amplified esophageal and GE junction cancers, the NCCN 2023 guidelines recommend chemotherapy with either fluoropyrimidine and oxaliplatin with nivolumab anti-PD-1 therapy, or chemotherapy with fluoropyrimidine, oxaliplatin, or cisplatin with pembrolizumab, another anti-PD-1 therapy, as first-line targeted therapy. For patients with HER2 non-amplified gastric cancer, first-line targeted therapy options include chemotherapy plus nivolumab. And these approvals for chemotherapy plus immunotherapy are based on trials such as Keynote 590 and Checkmate 649. In March 2021, the FDA approved pembrolizumab in combination with chemotherapy for advanced esophageal and GE junction cancer patients based on Keynote 590. And in April 2021, the FDA approved chemotherapy plus nivolumab for advanced esophageal GE junction and gastric cancer adenocarcinoma patients based on Checkmate 649. Despite the FDA approval of combining chemotherapy plus immunotherapy in all patients, irrespective of further biomarker selection, the NCCN guidelines has further recommendations based on level of evidence for recommending immunotherapy plus chemotherapy based on patients' PD-L1 CPS score, a predictive immunotherapy biomarker. For patients with tumors with a PD-L1 CPS score greater than or equal to 5, there's a higher Category 1 recommendation combining chemotherapy plus immunotherapy with nivolumab. And for patients with a PD-L1 CPS score greater than or equal to 10, there's a higher category recommendation for combining chemotherapy plus pembrolizumab compared to patients with a CPS score less than 10. Checkmate 649 was a phase 3 randomized multi-center global study where patients with advanced esophageal, GE junction, gastric adenocarcinomas were randomized in frontline treatment to chemotherapy or chemotherapy plus nivolumab. The primary endpoint of this study was progression-free and overall survival in patients with tumors with a CPS score greater than or equal to 5. The primary endpoint of this trial was met with the median overall survival improvement of 14.4 versus 11.1 months, and progression-free survival of 7.7 versus 6 months in patients with a CPS score greater than or equal to 5. The study also demonstrated a survival benefit in all randomized patients, irrespective of PD-L1 score. The median overall survival was 13.8 months versus 11.6 months, and progression-free survival 7.7 versus 6.9 months in favor of the immunotherapy plus chemotherapy arm. These results left to the FDA approval of chemo plus immunotherapy in all patients, irrespective of PD-L1 score. However, in subgroup analyses of patients with a CPS score less than 5, there were trends for less degree of benefit with immunotherapy plus chemotherapy. And this is reflected in the NCCN guidelines, where there's a higher recommendation for combining chemo plus nivolumab in patients with a CPS score greater than or equal to 5, compared to a lower recommendation if the CPS score is less than 5. Keynote 590 is a phase 3 randomized global multi-center study where patients with advanced esophageal and GE junction adenocarcinoma or squamous cell carcinoma were randomized 1-to-1 to chemotherapy plus placebo or chemotherapy plus pembrolizumab. Most patients in this study actually had squamous cell carcinoma, 73%, compared to 27% with adenocarcinoma. There were multiple primary endpoints in this study, including looking at overall survival in esophageal squamous cell carcinoma patients with a PD-L1 score greater than or equal to 10, and progression-free and overall survival in all esophageal squamous cell carcinoma patients, all patients with a PD-L1 score greater than or equal to 10, and all randomized patients. The primary endpoint of this study was met, and survival benefits with chemo plus immunotherapy were seen across all predetermined primary endpoint subgroups. Here we show the results of all randomized patients, where chemotherapy plus immunotherapy improved overall survival 12.4 versus 9.8 months, and progression-free survival 6.3 versus 5.8 months in all randomized patients. Patients with a CPS score greater than or equal to 10 also had survival improvements, with a median overall survival of 13.5 versus 9.4 months, and progression-free survival of 7.5 versus 5.5 months. Exploratory analyses of patients with PD-L1 CPS scores less than 10 actually showed that the survival difference was not significantly different. Together, these data led to FDA approvals of chemotherapy plus immunotherapy in esophageal and GE junction cancers, but with the suggestion that those with lower PD-L1 scores less than 10 may not be benefiting as much, this led to higher category recommendations in the NCCN guidelines for the combination of immunotherapy and chemotherapy for patients with a CPS score greater than or equal to 10, and a lower recommendation for the combination in patients with a CPS score less than 10. While chemotherapy and immunotherapy are improving survival in some patients, there remain ongoing clinical challenges for the treatment of patients with advanced upper GI tumors. We need to identify more reliable biomarkers to predict the efficacy of immunotherapy. PD-1, PD-L1 are biomarkers that can predict the efficacy, but there's temporal and spatial heterogeneity, and not all patients with higher PD-L1 scores benefit from the combination. We also need to identify better treatment options for patients with low PD-L1 scores, as these patients tend to not benefit as much from the combination as seen in these studies. Also, identifying optimal sequencing of immunotherapy, chemotherapy, and perhaps in combination with other emerging targeted therapies remains an ongoing question. We also need to identify additional targets in upper GI tumors. And beyond the first-line setting, we need to identify more active regimens in the refractory setting for patients who progress to second or third-line treatment. Thank you for watching this discussion about the challenges and unmet needs in patients with advanced HER2 non-amplified upper GI tumors. We hope that it has been helpful for you.
Hello, everyone. My name is Jaffer Ajani. I'm a GI medical oncologist. I work at MD Anderson Cancer Center. And today we are going to talk about emerging targeted therapy of gastroesophageal adenocarcinoma. So first of all, this is a very important area that is evolving quite rapidly. So the one way to understand is we have the phenotype in gastric cancer. One is diffuse type, intestinal type, but that is just looking at under the microscope. Then we have the genotypes established by TCGA and the Korean classification, but that doesn't really help too much in the clinic. Then we have these biomarkers. So biomarkers are the targets for therapeutics. So a biomarker, if you can identify and you don't have a drug, then it's not very meaningful. But now we have identified at least 4 biomarkers that we have drugs for, and these are HER2 overexpression, PD-L1 by CPS score, particularly CPS is more than 5, microsatellite status, particularly if it is unstable or high, and finally EBV. This is a virus that can induce gastric carcinoma. So today in my clinic, I have to check these 4 biomarkers for untreated advanced gastroesophageal adenocarcinoma patients. Now, there are some emerging biomarkers, such as Claudin 18.2 will be the next one, then FGFR2b, and finally DKK1 is under significant development today. So it may be that we will be checking these 3. And then since gastroesophageal adenocarcinoma are so heterogeneous that there will be more subsets, and these will be defined by KRAS amplification, occasionally KRAS mutation, or DNA damage repair deficiency, which is quite common in cancers. In gastroesophageal cancers, almost 20% of tumors are somewhat deficient in repairing the DNA. So FGFR, there are 4 genes. So this is a small family of genes, FGFR 1 to 4. And they're altered in cancers in general. All solid tumors, including leukemia, can have alterations in one of the genes. And this is about 7% of all tumor types. In gastric cancer, there is a splice variant that is called FGFR2b. This is a receptor in the embryonic gene family. In other words, it can promote rapid multiplication. That's why cancer cells use that. And it is frequently overexpressed, this particular receptor, FGFR2b, in almost 35% of untreated patients. And the reason it is very interesting is because we have a drug. We have several drugs, but for FGFR2b, there is an antibody called bemarituzumab, and this antibody has already been tried in the clinic. So essentially, the FGFR2b is an oncogene that helps the cancer cell to multiply and migrate. If you use bemarituzumab, then it will occupy that FGFR2b receptor and will block signaling, oncogenic signaling. In other words, the cancer cell will be deprived of that signal to multiply and migrate. At the same time, when there is antigen and antibody complex, antigen will be FGFR2b and antibody is the bemarituzumab. When that complex is formed, there is NK cell stimulation. So in other words, you accomplish 2 things. One is you prevent the cancer cells from multiplying. And secondly, you stimulate the immune system. So that is a potential advantage to control gastroesophageal cancer that express or overexpress FGFR2b. So as I mentioned, this bemarituzumab has already been in clinic in a randomized placebo-controlled phase 2 trial. And this trial was prematurely stopped. And the results are very suggestive of a trend towards benefit. So it's a small trial, only 155 patients or so. So we are not going to get very significant outcomes, but there was enough trend that the antibody is now being developed in pivotal trial, like phase 3 trials. So there are 2 major trials that are underway. One is called 42-101, which does not have immunotherapy, and 42-102 that does have addition of nivo. So the control arm in one trial is chemotherapy. The control arm in Another trial is chemo plus nivo. And then there are other molecules that are also being developed. So this is a very interesting biomarker, and it is unique to gastroesophageal cancer at the moment. But I suspect that Claudins, which is a very large family of proteins, are expressed in all tissues and many cancers, and they will all be targeted. But we are starting with gastric cancer. So essentially, cancer cells cannot survive by being attached to other cells because they like to multiply and migrate. And normal cells like to be adherent to other cells because they don't need to multiply and migrate. They're basically happy being attached to other cells and communicating with other cells. And the way this adhesion takes place in normal cells is by Claudins. Claudins are junction proteins that will tightly bind two cells together. So when Claudin 18.2 is causing adhesion among two cells, it is a tumor suppressor gene. So it will suppress the oncoproteins. So then the normal cells, there's no pressure to multiply. However, the cancer cells cannot survive being adhered to other cells. So what happens is they will cleave Claudin 18.2. And this way the cell can release itself. But the moment Claudin 18.2 is cleaved, it becomes an oncogene. And it will upregulate many other oncogenes. So we don't have time today to discuss this in detail, but principally in cancer cells, if Claudin is cleaved, then it is an oncogene, and that can be targeted. So it can be targeted with zolbetuximab, which is a chimeric IgG1 monoclonal antibody, and it will bind to Claudin 18.2, and it will result in, again, two different events. One will be stimulation of the immune system, NK cell, ADCC, and the second will be, it will prevent the cancer, downregulate all the oncogenes, so the cancer cell cannot proliferate and cannot migrate. So that is an advantage. So there was a trial called FAST trial. This was completed in Europe. And again, this was a small trial, but showing considerable advantage in patients who received zolbetuximab, particularly where the Claudin expression was very high. In 70% of cells, if there was Claudin expressed, those patients benefited substantially. So essentially what the pharma has done is focused on patients where the Claudin expression is very high. And two major phase 3 pivotal trials are already completed, and they're both positive. We have results from Spotlight showing prolongation of progression-free survival and overall survival. And we have press release on the trial called GLOW, G-L-O-W. And there also, there is the endpoints are met, progression-free survival and overall survival. The difference between these two trials is just the chemotherapy schedule. So in Spotlight, chemo is given every 2 weeks, and in GLOW, it's given every 3 weeks. So there are, fortunately, what we are discovering now is that there are many subsets in gastroesophageal adenocarcinoma. So in other words, not every patient's cancer is using the same, what we call drivers, driver genes, driver proteins. So 10 years ago, I would be treating every patient with the same treatment because I assumed that everyone's cancer is the same. But now we know it is not the case. So we described already potentially 6 biomarkers that we will have to check. And that will be PD-L1, HER2 microsatellite status, and EBV. And then the one that is coming very closely is Claudin 18.2 and followed by FGFR2b, and perhaps all FGFR genes. And at the same time, there are emerging biomarkers like TKK1. So I suspect that that will become very important because that molecule is being developed right now in randomized phase 2, but it will go into phase 3. And as you may know, that KRAS is a very hot topic in gastrointestinal cancers, also lung cancers. So there are many molecules that can address specific mutations of KRAS, or there are some pan-KRAS molecules that can inhibit whatever abnormality there might be, such as amplification or specific mutation. But what is really exciting is the other platform that is developing, which is the what is called the agnostic treatments. So these are biomarkers that, irrespective of tumor type, if you have it, then you can use the drug. So this is NTRK fusion, RET fusion, BRAF mutation, and TMB high, tumor mutation burden. If it is high, for example, 10 mutations per megabyte of DNA, you can use immunotherapy. So we have all these biomarkers that we will have to address in the clinic, and doing just the tissue-based analysis is going to be challenging because we don't have a lot of tissue available. But at the same time, there are these technologies that are making treatments more effective. So one will be BITE, which is a multi-engager. So one antibody can engage a component of immune system. The other arm will engage an oncoprotein. So we are kind of addressing both sides. If you just treat with, if you target just the immune system, the cancer can modify itself. But if you target both the cancer and immune system, perhaps we will get a greater advantage. So BITE is one. Bispecific, trispecific antibodies that engage multiple. Trispecific can engage 3 different targets, so that you're gaining a greater advantage when you're trying to disrupt cancer progression. And then, of course, cell therapy and the new technology of antibody conjugate, especially Claudin 18.2. Now there are many molecules that contain zolbetuximab, a linker, and a cytotoxic moiety at the same time. So all 3 components can be targeted to cancer cells for greater advantage. So I think we're in very exciting time at the moment. And also we have to pay a lot of attention to the development in order to treat our patients properly. I want to thank everybody for listening to this presentation today. And I hope you benefited from this, and you will be able to discuss this with your patients and with your colleagues. Thank you.
Hello, my name is Nataliya Uboha. I am an associate professor in Department of Medicine in Carbone Cancer Center at University of Wisconsin, and I specialize in treating patients with gastrointestinal cancers. So there are now a few different modalities that we utilize to better characterize patients' tumors with gastroesophageal adenocarcinomas. We use immunohistochemistry, which is probably the easiest method to use, and we use immunohistochemistry to look at PD-L1 expression, HER2 expression, and expression of mismatch repair proteins. So specifically for PD-L1 expression, we utilize CPS, which is a combined positive score. This is different from tumor positive score, which is used in other tumors such as non-small cell lung cancer. Combined positive score looks at the presence of PD-L1 expression not only in tumor cells, but also in immune cells that are present in tumor microenvironment. And this is the score that's utilized when we look at patients with advanced gastroesophageal adenocarcinomas. HER2 probably has the longest track record in the characterizing of patients with gastroesophageal adenocarcinomas. HER2 expression is present in about 15 to 20% I should say, HER2 overexpression is present in about 15 to 20% of tumors, and is also evaluated via immunohistochemistry. Although we do utilize fluorescent in situ hybridization as well when we get an indeterminate score for HER2, such as 2+. 1+ immunohistochemistry score for HER2 is considered negative, 3+ is positive, but whenever we have tumors with 2+ HER2 expression, we have to further validate whether this is actually tumor with overexpression versus low expression with subsequent fluorescent in situ hybridization of FISH assay. And MMR protein expression looks at the presence or absence of mismatch repair proteins. And this is a test for us to identify patients who potentially have microcellular instability or have deficient MMR expression. And those patients whose tumors have deficient mismatch repair protein expression would be more likely to respond to immune checkpoint inhibitors. NGS testing, your next generation sequencing, is now utilized very frequently for patients with advanced tumors. And this is the test that looks at many different genes at the same time. And we can look for gene amplifications, gene mutations, fusions, all at the same time. And we typically use this assay for patients with stage 4 disease. At ctDNA, in this setting, we talk about looking at liquid biopsy to look for genetic mutations. ctDNA assays can be used as a quick way to look at what mutations are present in the tumor. We typically utilize ctDNA testing when we don't have enough tissue for testing, or when we need a result quicker than what we can typically receive with tissue NGS testing that can usually take 2 to 3 weeks. Now, I have to say that a negative result from ctDNA has to be interpreted with caution, because occasionally we may not detect the present mutations or amplifications because of the tumor characteristics, such as potentially tumors not shedding as much DNA into the bloodstream. So at this time, there are 3 established biomarkers that we use to decide on therapies for patients. One of them is testing for deficient mismatch repair protein expression or looking for microsatellite instability with PCR. We now have an approval of pembrolizumab in a disease agnostic fashion for patients that have tumors with MMR deficiency or microsatellite instability. And so certainly testing of tumors in advanced stages and also in early stages is very important. Pembrolizumab is approved for patients with MSI high tumors. In our practice, we test all GI cancers, regardless of stage, for MMR expression with immunohistochemistry. Another biomarker that is utilized for treatment selections for patients with advanced gastroesophageal adenocarcinoma is PD-L1, and we talked about it previously. We looked at CPS score. And PD-L1 helps us determine which patients are more likely to respond to immunotherapy. We use this biomarker in advanced setting only. And at this time, we primarily use nivolumab in combination with chemotherapy in patients whose tumors have PD-L1 CPS 5 or greater. Pembrolizumab can be utilized in esophageal cancer, adenocarcinoma specifically. The cutoff is a bit different. We typically use PD-L1 CPS 10 or greater for pembrolizumab selection. It is important to know that in the US, both nivolumab and pembrolizumab are FDA approved regardless of PD-L1 expression. However, we do see better activity of these agents in patients whose tumors have PD-L1 expression. And lastly, HER2. HER2 is present. HER2 overexpression is present in about 15 to 20% of patients with gastroesophageal adenocarcinoma. It is important to test for HER2 overexpression at the time of diagnosis of advanced disease. And those patients who have HER2 positive tumors should be treated with anti-HER2 agents. And it is trastuzumab in combination with chemotherapy and immunotherapy in first-line setting. And in later-line settings, we now have trastuzumab deruxtecan as well that can be used after progression on trastuzumab. it is exciting to see that we are starting to have more targeted therapies for patients with gastroesophageal adenocarcinoma. I think Claudin 18.2 as a biomarker is most ready for prime time. Claudin 18.2 is a tight junction protein. It is overexpressed in about 39% of patients with gastroesophageal adenocarcinoma. And on a molecular level, we can see Claudin 18 fusion as well, but in a smaller percentage of patients. This is an exciting biomarker because we have a number of different agents in development. So the results of 2 phase 3 trials that looked whether additional zolbetuximab to chemotherapy in first-line setting improves overall survival in patients with Claudin 18.2 positive tumors. And indeed, both of those trials, Spotlight and Glow, demonstrated that zolbetuximab results in improved overall survival. As such, I am anticipating that soon we will all be testing patients' tumors for Claudin 18.2 expression, and hopefully we will be incorporating a new agent into the treatment of our patients with advanced disease. FGFR2 is another potential target. The data is not as mature as with anti-Claudin agents, but FGFR2, first of all, it's a fibroblast growth factor receptor, which is a tyrosine kinase receptor. It can be dysregulated in many different ways. In gastric and GE junction adenocarcinoma, we typically see increased expression of GFR2, although amplification can also be seen in a small percentage of patients. An antibody, bemarituzumab, is an antibody that binds to FGFR2b, which is expressed on gastric and gastroesophageal adenocarcinoma cells. And this antibody was evaluated in patients with advanced disease, and I guess in a similar design to the studies that were done with anti-Claudin antibodies, when patients were treated with bemarituzumab in combination with chemotherapy, and if those patients had tumors with high FGFR2 expression, they experienced overall survival benefit. The data with bemarituzumab is early; it's only phase 2 data, and so we need to see confirmatory results in phase 3 data before hoping to incorporate this agent into our practice as well. It is great to see that we have more biomarkers and more way to really tailor treatment to each individual patient. However, this comes with challenges as well. As we are getting more and more biomarkers available for testing, tissue availability becomes an issue. And certainly when we only have one biopsy or one core from biopsy for individual patient, it may be challenging to send that one biopsy for multiple different immunohistochemistry tests, as well as NGS testing, and also a number of our patients are participating in clinical trials that require testing as well. So certainly tissue availability is becoming a challenge, and it is great that we have liquid biopsies as well that could supplement our ability to do at least NGS testing. The other challenges surrounding biomarker testing in both spatial and temporal heterogeneity. I think it is characterized rather well for patients with HER2 positive tumors. We know that HER2 overexpression can change over time. This has been well described in patients who have HER2 positive tumors, are treated with trastuzumab in first line, and upon progression, their tumors lose HER2 expression. So repeat testing is absolutely necessary when we use targeted agents, repeat testing over time, but we're also learning that different tumor sites can express different amount of each biomarker at the same time as well. And so this is going to be a learning curve, have to utilize all of this information when we choose patient treatments. And speaking of learning curve, given that we have a number of different antibodies used now for biomarkers, it is a challenge for even our pathology colleagues to incorporate all of this into our standard practice. For example, PD-L1 combined positive score had used different cutoffs, 1%, 5%, 10% across different studies. The different studies also use different antibodies. So all of this will need to be streamlined and really simplified so that it's easy to incorporate into our practice. And another important question will be, what do we do for patients who have an overlap in their biomarker, in their tumors and biomarker expression. For example, what if the patient has a tumor that is both PD-L1 positive and Claudin expression positive? And again, this is something that we will need to learn how to approach as we start to utilize both the biomarkers and the drugs in our practice. But these questions have not been answered yet, and hopefully will be answered over time. But in summary, it is great to see that there are more biomarkers and more ways to personalize therapies for our patients, because this ultimately will result in better outcomes for our patients. Thank you so much for watching this discussion about personalized treatment for advanced HER2-negative gastric and gastroesophageal junction cancers. We hope that it has been useful for you.